Thank you, ma'am. Thank you, sirs. From classrooms to clinic, shaping practice through innovative medical education. As we move on to the next session, an open forum on institutional approach to align assessment and learning design. How do we do it? May I request Dr. V. N. Mahalakshmi to anchor this session. And for this session, we have Dr. Nicola, Adjunct Professor, National University Hospital, Singapore, Dr. Kirtana Nayak, KMC Manipal, Dr. Sayaka, Project Professor, Akita University, Japan, Dr. Jyoti M., Professor of Microbiology, Academy of Higher Education, Karnataka, to contribute to this session.
You're always in the center. Okay, thank you, Aarti, or thank you, Aartis, for that introduction. We'd move on to this open session. We thought we'd keep this a little light and live. Okay, we actually wanted to discuss how we can align the institutional approach to ensure that the assessment and the instructional designs align. So that is what it is. So when we actually thought about this session, we had only two objectives in mind. One was the first question, or the most important question: why do we need to align? Is there a necessity to look at this particular question? The second one is, how can we share certain best practices which already exist? There's something called as a lost pilot, right? Many of us would have done, seen, or heard about some things which are certain gems which are tucked away in one corner elsewhere, but never come into limelight because nobody ever asked us, have you ever done something like that? So our idea was to dig up certain best practices, the lost pilots. So these are the two objectives. And when we thought about the session format, we thought we'd do it more like a symposium panel rather than like a formal panel discussion. So let me start with this why align question. Because it brings clarity. We have heard a lot of discussion about how assessment drives learning. But I would rather think about assessment opens about new horizons, where you can go, where you have been, where you can go, and how you are doing things. So that is one. It also brings back to the focus. If one step in the ASCII station is done wrong by everybody, that means the way you have taught it or the way he has understood is gone. So you can actually focus assessment. It is like a diagnostic tool. Tells you exactly where the competence is lacking. That's the second point. And when you have engagement, you should see the Kahoot tests or the Mentimeter quiz we do. That's the one which actually engages the students. So assessment brings in a lot of engagement to the students, apart from feedback and improvement. It also helps us to validate the tools we are using. We assume that certain things work and certain things don't work, but to question whether it really does, to make the data-driven decisions, right, based on reliability and validity. So that is very important. And it also helps us how we can use our resources effectively. Just because we have certain resources, it doesn't mean that we can use them. Or worse still is, you say, I don't have any resources, so I can't do anything. I'll just continue to do what I've been doing. So that's equally bad, I feel. And the last, but the elephant in the... So I would like the panelists to introduce themselves and tell us what is that you are bringing into the table for this particular discussion. Maybe I'll start with Nicola.
Thank you. Hi, I'm Nicola. I am from National University of Singapore. Firstly, I'd like to thank Dr. Maha and the iCON organizing team for inviting me. I'm very honored to be here. I am a pediatrician by training. And so, sorry, I forgot what was the question again.
The question is, what is that you bring into the table
what do I
for
bring?
this discussion?
Okay, sure. So I am no expert with assessment. My role is in overseeing communication skills teaching. And I'm also the director of the Standardized Patient Program at the National University of Singapore. So I'm going to share a little bit, I think, through my slides about what we do at NUS. I'm not sure if it's the right or the wrong thing to do, and it's constantly evolving for us. So I will share a little bit about that experience. Thank you.
Thanks, Nicola. Yeah.
Hello, everyone. I'm Sayaka Oikawa from Japan. I'm an emergency medicine physician as well as working in medical education department. So I'm doing many educational activities, but focusing on assessment. I am a committee member who are renewing the OSCE system, national-wide OSCE systems, and we are now reforming our OSCE system in my country. So based on our experiences, maybe you will find some tips and then we can share some discussion. Thank you very much.
Thanks, Sayaka.
Hello everyone, I am Kirtana from Kasturba Medical College, Manipal. I am Professor of Physiology, currently heading the Department of Medical Education at KMC Manipal. So I will attempt to cover the need for continuous internal assessment in the CBME curriculum and how do we use technology and what tools and strategies can we use for doing continuous internal assessment and formative assessments. Thank you.
Thanks, Kirtana.
Hello, good morning everyone. I am Jyoti from KLE University, Belagavi, Karnataka. And I'm the professor of microbiology at JN Medical College and the controller of examination of KLE University, which has got 7 disciplines and we have 150 courses to go. As a controller of examination, today on the table I shall be sharing, we all know the technology being applied for objective assessment. Now the subjective questions or the written exam part of it, we have adopted the technology in the form of paperless exams or the ePad exam. ePad is not iPad, it is the exam pad, which I'll be sharing the details that we have already implemented that for 400 students. This year onwards, another 350 students will be pulled in. And we shall be also be able to draw the statistics after assessment of the subjective questions or the long question, essay type of questions. Thank you.
Thank you for that nice teaser. And as you see, this is ICON girl power. Only all ladies are there in this panel discussion. Okay, jokes apart. Now that we have seen this, let's start with the symposium format. So I would request each of the panelists to stick to their topics and present the assigned topic in about 7 minutes. Would that work? Yeah. So we'd go with Nicola. She's going to share certain best practices about teaching, especially teaching difficult things like communication skills, professionalism, and ethics using standardized patients. She's one of our knowledge partners from the Asia Spec. Over to you, Nicola. You can go to the stage. Thank you.
Okay, thank you very much. So I will quickly share some of our experiences with trying to align instructional design with assessment. So as you can see from this diagram, everything needs to be aligned. So it's a tall order, aligning our learning objectives and goals, as well as our teaching activities and the feedback, as well as the assessment. So I'm going to talk from the perspective of junior years in medical school, and then now followed by the more senior years where it gets a little bit more complicated. So in the junior years at NUS at least, we teach basic communication skills as well as physical examination skills. And the way we try and understand this is basically we're trying to teach them the highway code. So learning to drive, you need to learn the highway code. And so learning to be a doctor, there are certain basic skills that you will need to acquire early on in the education. So the approach that we've adopted is being transparent with the assessment tool. So at the end of second year, in school, essentially, they will be assessed at their first OSCE assessment. So there are several stations, and a lot of it is physical examination and communication skills, or the basic history taking and incorporating communication skills. So we're very transparent with the rubric that we are assessing them by. They know what the steps are that are expected of them. They use this to study, and they use this to work with our standardized patients. So this is just an example of a assessment or checklist for cardiovascular examination. And then this is the scale that we use to teach communication skills. So it's the Master Interview Rating Scale, which originates in Arizona. But basically we learned it and we tried to train our SPs as well as our examiners to observe for these communication skills behaviors and to give relevant feedback to the students. So this again is transparent to the students. So in terms of instructional design, I think we kind of communicate the content through interactive lectures as well as videos particularly for physical examination. And then they get to practice. So I think this piece is quite important. They come to class and they practice with our standardized patients, as well as PITAS. PITAS stands for Physical Examination Teaching Associate. So these are SPs who are quite able and quite experienced, and we train them to teach the physical examination techniques. So they just teach the steps. They do not teach any abnormalities, they just teach the steps, and the students can practice on them, and they get immediate feedback on their skills. And if they need corrections to be made, the PITAS will guide them through that. And then that's subsequently followed by self-directed learning. So we put them in the room with the SPs or the PITAS, and they practice on their own in the time that's been allocated to them. So that removes the time pressure, because a lot of times in tutorials or learning sessions, there's a lot of pressure of time. So that's our instructional design, and it seems to work quite well. Our pass rates for phase 2 examinations is very high. And so I think in terms of learning basic skills, this probably works. Then you move on to the more complex clinical years where they have to approach patients and learn how to manage the patients. And so this chart kind of shows the complexity that comes along. So as you move towards the left of the chart, you will see more lines that are joining, intersections, and then they start to need to analyze, to theorize, to hypothesize. And so all of these are complex skills. It becomes a little more difficult to teach and a little bit more difficult to assess. So it becomes complex. So I think you've heard a lot about clinical competence already. I will not belabor the point, but there's a lot of components to this clinical competence. And so what exactly are we trying to assess? It's not just their cognitive abilities, but really is their ability to problem solve, to judge what the problem is, and a lot of interpersonal skills and professionalism, as you've heard from Dr. Sanjeev. So instructional design, I'm going to share with you the problems first, okay? So the problem is the danger of silos. I'm not sure if it's the same for you, but we do teach them in individual components throughout medical school and in individual postings. So, and then we try and teach them ethics, we try and teach them communication skills, we try and teach them practical skills, and they don't see how it all links together. So I think that's the danger of the curriculum that we currently deliver. And also opportunistic exposure. So a lot of the time, so in NUS, I think a student may be able to go through medical school without having seen a patient with a pneumothorax, say. So some of these high acuity, low occurrence situations, the student may not see. And I think that's where, as people who administer the curriculum, we need to be very aware and need to track our students so that we know that they have seen these important clinical scenarios, and so we are confident that when they come out, they will be able to manage that. So I think the ways around it, I think as you've well heard throughout this conference, is simulation. I think that allows for exposure, firstly, to low occurrence situations. It allows them to apply knowledge, not just have that content in their heads, and then to be able to watch them work or process data, I think. So many things are flying at them at the same time in simulation, and they have to prioritize and process the data in order to come up with a solution. So that's probably one way to overcome the silos and maybe help it to come together. And then longitudinal tracks, I think. So for professionalism, communication skills, and ethics, tracking them and trying to spiral up on their skills, I suppose, as they move through medical school is an important aspect that we need to pay attention to. I think the challenge is assessing that. I think you've heard from Dr. Sanjeev about portfolios. That's one way to do it, so that you collect formative data and the student gets feedback along the way so that they grow. And I think the beauty of that is that it can be individualized. So each student has a different rates of learning or different skills that they need to work on, and in that way, it may be able to be individualized. So the assessment conundrum. it's a problem. Okay, so how do we assess? I think blueprinting is very important. So we've talked about this already, and we just need to look at the overall assessment plan that we have for our students and make sure that we're targeting all the important components in the blueprint. As you've heard, OSCEs are segmented, they're artificial. So although we do it all the time, perhaps it's not the best way to assess, or it's not the best investment in time. I think you heard from Dr. Tajinder Singh about long cases. I think that has the highest reliability I noticed on his chart. Even one has a almost 0.7 reliability. So I think not to lose the long case. We're always talking about efficiency of time and how exam stations need to be shorter and shorter. I think investing that time in allowing the student to process and actually work through the patient's problem may be the way to go, or maybe something that we need to hang on to. And then just the last bit about this conundrum, some things that are not tested or maybe not specifically tested, things like professionalism, prioritization, humanism, and just plain common sense. We don't really test these. And how do you do that? I'm not sure. Okay, so I don't have the answers, but some things to think about. So that's all I have to say. Thank you very much.
Thank you, Nicola, for that very nice and crisp presentations. We'd move on. Let's talk about how do we go about assessing clinical competence. And since Sayaka is working with the institute which designs the national OSCE exams, and she's been part of it, I think she'd be the right person to tell us about what are the best practices in that area.
Hello, everyone. Okay. So my theme is best practice in assessment of clinical competencies. I'm not sure our practice is best or not, but maybe we are having many problems and I try to overcome these problems. So maybe our trial will be helpful if you organize a large-scale OSCEs. So let me introduce what is about medical education system in Japan. So we have 47 prefectures, and each prefecture has at least one med schools, and about 9,000 medical students enter the medical schools and the graduate medical school, and more than 90% are under 20 years old, and I mean first year. And less than 40% of students are female students. And we started national-wide large-scale OSCE in 2005. So we have less than 20 years of experiences. And this is all about our curriculum schedule. And after high school of 3 years, the student entered a medical school and then in the 6-year curriculum, the last 2 years or 2.5 years, they have to do clinical clerkship. And before clinical clerkship, they have to pass the computer-based test, which is 100% knowledge-based exam. And also they have to pass the pre-CC OSCE, which is performance-based exam. And after clinical clerkship, they have to take national exam and also have to pass the post-CC OSCE. And after 2 years residency training, they go to specialty track. And some specialties like surgeon, they have to spend 5 years to take the board certification exam. So let's focus on stakeholders. So we basically have two ministry of the government body have responsibility in the education. And before graduation, the Minister of Education, and after graduation, the Minister of Health are taking in charge medical education. So entrance exam, Minister of Education, and each med school have responsibility. And computer-based tests and pre- and post-CC OSCE are conducted by CATO, which is not governmental body, but is a national-wide organization. And national exam is conducted by Ministry of Health. And board certification exam is conducted by another organization. So as you can see, these high-stakes exams are conducted by different bodies. And large-scale OSCEs are conducted nationwide before and after the clinical clerkship. And under the line, you can see Medical Practitioners Act has been reformed and then some requirement have for the medical student have to pass the exam to get the medical licenses. And this organization is actually conducting OSCE and computer-based examination. But the problem is this organization is not such big one. I mean, they don't have many human resources. So they have to rely on each medical schools to help them. And CATO has some specific checklist, and the student can watch it on the website. And they have to have some idea what kind of checklist do I have to pass to enter the clinical clerkship or finish the clinical clerkship, that kind of things. And this is model core curriculum for medical education in Japan. So we reform this curriculum every 5 or 6 years. And the last year, we reformed this curriculum. And the OSCE station is created based on the content of this curriculum. So let me skip this. So this is a pre-clinical clerkship OSCE. So we have 8 mandatory scenarios currently, and the 2 optional scenarios. It depends on each med school whether they do optional scenarios or not. And so as you can see the below, left below, we have 2 assessors in each rooms, and sometimes standard patients are in the room or sometimes without SPs. And this is post-clinical clerkship OSCE in my university. So my university is the one of the university who are conducting the big number of scenarios for post-CC OSCE. But our university located in rural area, so we don't have many human resources. So we are struggling with that kind of hard work. So in OSCE is a skill-based exam, so you can imagine when you increase one scenario, that means you need more people, more assessors, more rooms. So it's really hard working, especially administrative person. They are sometimes almost burned out, doing many kind of things to do one OSCE. So that is a big problem. So we actually do 16 scenarios for post-CC OSCE, and 3 of them are long cases, and 13 of them are short cases. So like above, urology, emergency medicine, pediatrics, ENT, orthopedic surgery, clinical laboratory. They create 5-minute scenario. Oh, sorry. And the CATO, the organization conducting OSCE, they created long cases. So we do the combined long and short cases. And the faculty member observe from the control room to make sure that everything is going on okay. So what kind of problems we had is the first of all, we have to do validated and reliable OSCE exams because this is high stakes. So in order to do that, we need to create some blueprint and incorporate systematic assessment method. And also in OSCE, it can be very overwork. So we need to make have some method to overcome that, the problems. So we are now discussing a built big OSCE center in Japan, but we are struggling with many, many problems, budget problems, human resources problems. So my message here is when your nation is much, much bigger than my nation, but if your nation try to do some nationwide OSCE, please start with discussion and please continue program evaluation again and again. So that is my take-home message. Thank you very much.
Thank you, Sayaka, for finishing dot on time. She brought out a very important message of how you need to plan and look at it, because we had that discussion yesterday about the next exam. And ever since the word next came, we had nothing but controversy surrounding it and a lot of heartaches and faculty getting disappointed, disillusioned about it. So I think we have to look for the silver lining in each situation and see how we can take things forward rather than trying to sit in an armchair and keep finding faults. So that is what we should be doing, or that And when we are talking about this outcome-based curriculum, because that's the one which is mandated by WFME and almost all the nations. See, this particular talk came about when I listened to the outcome national level exit exams. There was a discussion in the CRME conference which was being held. And small countries like Thailand, Vietnam, they are doing national level exit exams for 10 years, 15 years now. So what are we, such a big country, why we have to make so much of hue and cry over it? So that is what we wanted to this. So when we are implementing CBME, and one of the most important component is the formative assessment, continuous internal assessment. So how do we go about it, and how do we make things work at ground level? We'll have somebody who is doing it on a routine basis. I call upon Kirtana to present.
Thank you, madam. So with assessments in CBME, we know that the emphasis has been on formative. That's why summative figures as a small circle in the backdrop and quanta of formative assessment that needs to be done. With the necessity for FA and the sheer burden on teachers, how do we use technology to conduct formative assessments and continuous assessments? What are the tools and strategies for conducting continuous internal assessment, and where do we place CIA, continuous internal assessment? So continuous assessment is not just one thing. It can be represented as a continuum with two operational extremes. We had this discussion yesterday. It could be fully structured, planned mechanism like the part completion test, the sessional examinations, the monthly test, the weekly test, with the purpose of generating scores for the continuous assessment, summative purpose. On the other extreme, it could be unstructured, even spontaneous methods. For example, the teacher can decide to ask a question in the middle of the class with the sole purpose of making immediate adjustments in the instructions and give precise feedback. And the NMC has come with the new scheme for the internal assessment from the batch of 23, separately for theory as well as for practicals. There is sessional examinations, the part completion test, there is library, there is home, there is LMS assignment, there is SDL, and for practicals there is assessment of certification of skills, AdCom, research and whatnot. So we at Kasturba Medical College, we have a learning management system which is intuitive in its design, and we use this for submission of assignments, for tracking students' progress, as well as document logbook as part of CBME. When we conduct quizzes using this platform, we use this either for increasing student engagement, and some departments conduct quizzes periodically for generating scores for continuous internal assessment. The digital learning content, the virtual labs can be hosted using LMS. We can construct assignments using LMS, and we can get learning confirmation on whether the students have completed this activity using the LMS. Students can submit their assignments as text, as PDF and videos for components such as early clinical exposure, AdCom. Very importantly, for authentic assessments, for certification of skills, we can observe the skills, observed in person activity, and we can grade using rubrics. These rubrics we can put it in LMS, we can observe the activity in person, and when the scoring is done externally, we can enter the numerical score directly into the gradebook with the feedback published to the students and decision marked whether certified or not. And those students who require remediation, they can practice these skills, and once they are proficient, they can upload these skills on LMS and the teacher can observe and certify. All the activities which are rolled out from this platform, which is captured in this platform, it will be in the gradebook, and the departments can pick and choose the assignments for the calculation of internal assessment, and all the activities which are done using LMS. All the content and assignments will stay as a repository which can be used subsequently for other batches. So instructional strategies should manage time in flexible ways and should harness the benefits of collaborative learning. You can construct innovative assignments, you can release cases in groups, you can make the students post the knowledge gap using the discussion forum moderated by teachers. We have attempted all of these. You can push the students to do literature search and then make the group submit the assignments as a group. We have published literature on team-based learning, and we are progressing to use the learning management system to conduct TBLs. The clinical departments can use the LMS for documenting logbook. I will not get into the granularity of this, the examination pad. Jyoti madam will do this in detail. So we at Manipal from last 9 years, we have been using paperless examination using ePad, not just for our university examinations, for our sessional examinations also. So this is a custom built device which the students will use exclusively for writing descriptive exams. So it requires biometric authentication, and the question paper gets released from the cloud at the allotted time, and the answer scripts also get allotted at the end of the duration of the exam. So this is a short, I'll just start this video. So these are our students taking the ePad examination. So it has all drawing tools, it has calculator functions also. All the data is end-to-end encrypted, and the MCQs are auto-evaluated. The examiners will have to log in to the exam cloud using credentials, and they will have to do the evaluation of the descriptive questions. So the advantage of examination pad is the simultaneous evaluation of the same script is possible by multiple examiners. We recently finished the university examinations, and I am a physiologist, so I corrected one essay in paper 1, and I did that for all 650 scripts. We have 650 students in our university. So it enhances inter-rater reliability. If an examiner is uniform or strict, it remains same, so for the same question throughout all the scripts. And definitely the examination happens faster, cycle is faster, and there is quick announcement of results. And if the question is tagged to competency, and if we have question-wise and student-wise marks, then OB analysis is also possible. Just like how Mahalakshmi madam said, in OSCE, if we have data, we can find out each station how student is performing, and 10 different stations, how are the student performing. Yeah. So FA and CA, how much to do? FA is what the teachers will practice in the classroom. It's his or her personal choice. CA has to be the vision of the department and that of the organization. Use variety of assessments, space it, use technology, and if you get students hooked into learning, there is no reason why they should not do well in summatives. Thank you. Please do visit Manipal.
Thank you, Kirtana, for that invitation. Already 3 trips over this year to Manipal. Okay. She brought out very nicely, because every time the NMC comes up with the new ones, no, the 1000-mark one which has come, all the teachers were looking at it. We have very few faculty, and we have increasing tasks day by day. So how do we go about doing it is the frustration. Maybe the technology is in our fingertips. That's the answer, I think, to that question. Thank you for that very nice presentation. So we'll move on. We have somebody who is going to tell us about how technology can be used in summative assessment. Formative is much more bigger circle, but summative is much more at higher stakes. So we have Jyoti, who would tell us about how she has harnessed technology and using it consistently for the high-stake university exams.
Good afternoon, and My introduction already done. I shall be speaking on implementation of technology in the summative examination. Though it is summative examination, we start it with all the exams they are going to write. We take fresh batch of students, and of course they will start from their formative assessments. Last year we have started this with 400 students of dentistry, Ayurveda, homeopathy and nursing students. The key features of this system is they are end-to-end encrypted, completely paperless, cloud-based solution. The data is, the exams are completely secure and transparent, easy and effective interface for all the stakeholders, including the evaluators and the administrators and the students. It consumes less post-examination processing time. Even the pre-examination QP setting is very easy and user-friendly, and easy storage of and access to the data for any RTI purposes later on, and excellent feedback. That is a most rewarding thing that we are going to expand even this year for medical and some other courses this year. As I said, we have 7 disciplines. We have taken both students and faculty feedback, which is highly encouraging. It is 96 to 98% effective and encouraging. Satisfying. So as I said, this is not an iPad, it is an ePad, it is exam pad and completely customized ergonomically for making it student friendly, user friendly. This is mainly meant for writing exam. It never gets connected to the internet. That is the most important point of it. And it is ergonomically designed, dimension wise also, and also the feel wise, just like a paper exam pad, including the thickness and the dimensions, as I said. And it has got long battery backup of about 12 to 15 hours, so that we can have 3-hour sessions, 3 per day. So it also has got chemically etched patented technology surface. The surface is just not like our glass surfaces like our mobile phones. It completely feels like the paper, because it is chemically etched patented technology, mainly meant for long hours of writing, and nothing else works. For example, even if our nails scratch or some other items like bangle scratch, nothing makes a mark on the papers except the stylus that works. So these are the important key features. It is mainly meant for exam. That is how it is called as ePad. Other key features are, like, as I said, the questions can be de novo. QP authoring is very easy. They can write the questions on their own, or they can pull the questions from the tagged question bank. Another important feature of our university, we have got the question banks, huge robust question banks, pre-validated by a very important innovative method that the faculty were gathered. And we have the pre-validated question banks of lakhs of questions, and which in the next stage we are planning to tag it with the software, so that the QP authoring as per the blueprint can also be going with the software, and it can be even automated. Presently we are doing the manual QP authoring, though the questions are being drawn from the pre-validated question banks. Picture. Another important feature which exactly suits the requirement of the CBME is we can have audio-based questions, picture-based questions, video-based questions, which will definitely work for testing our soft skills or the non-technical skills like EdCom. For valuation also, it is very pleasing. Earlier we had, though on-screen valuation, the papers would be uploaded after scanning, and our scanners are quite old and it was too dull, the screen was dull. Now it is completely the reality. The pictures look so live and the screen looks live, and it is very the users are very happy for evaluation. And another thing is, at the end of it, we can go for PO, COs matching, that is program and course outcome can be matched. Not only that, the item analysis or the statistics can be got at the end of this. Sorry. This is how our students have drawn the diagrams. Some more of them. Just to cut down a little bit on my talk, I will show you a brief video. I'm not sure where I tagged it. Anyway, I will go further. Once the examination starts, right at dot time, the QP opens up. Even before that, the students don't have to carry anything other than nothing, no paper, etc., other than a water bottle. That also is not allowed. It is allowed to be kept on the ground. Iris authentication takes place, and the question paper opens only after the student is identified by the system. This is how the digital hall ticket opens up. Stylus calibration is another important feature of this. The student can practice his own style of holding the stylus, and it can be calibrated according to the style of holding. That is to get a better handwriting on the e-pads. Our student feedback is that initially just one exam they will be little uncomfortable, but later on they just don't want to look back. This is how the screen blanks out just 1 minute before the start of exam, and the question paper opens up. This is the QP view, wherein initially we can have the multiple choice questions. This is how the QPs are marked. It doesn't say that it is a right answer, but that is a marked answer. These are the match the following type of items. And this is for descriptive answers. A blank page appears, and there are so many varieties of papers there that the students can choose. I'll come to it. N number of pages can be added to one descriptive answer just by scrolling up and down. And these are a number of features which are very student friendly, that they can choose different type of thickness of pens. They will have a color palette to underline the text matter. They will have different pen tip sizes. We have standardized some of these features for our university, that they have to follow certain rules regarding choosing the color and the thickness of the pen. And the students also have got standard shapes to draw, to take them for drawing any pictures. Even as I said, the picture based questions, they can take it from some tools that we will upload here. For example, if you give a bone, it can be marked and it can be used for labeling purposes, etc. As I said, different types of the pages can be taken, chosen, and the size and shape, highlighting, block erasing, do, undo, all these options are available. Another important feature is the student dashboard, wherein he will get an idea about what is the current time, what is the time left, and flagging of the question is another important feature of this. The student can revisit the question, and the system will not allow him to submit the answer sheet unless the flagged questions are revisited. So n number of features are there which are really user friendly. This is a student dashboard giving the details. And at the end of the exam time, it gets automatically submitted even if the student has forgotten to submit the paper. If quickly I just want to show a video, I don't know, I just did it in maybe another PPT. Where is the escape button? Yes. I'll do that. Just minimize. Sir, I'll just take the questions after this, please. Sound, please. Somehow it is not playing.
Jyoti, maybe we can do the video a little later.
Okay.
For the interest of time.
Okay, I'll take the questions then.
No,
Video is not.
the questions we will take as a panel at the end of it. The only
Yeah.
question which has come, which has leaked out by Sanjeev sir, is how much it is going to cost. Maybe you can do that.
Okay.
Oh, you got it.
Yeah, I got it, ma'am. Sorry for volume, please.
We are happy to share that we have introduced paperless digital e-pad exams at our university. Our students are presently writing the exams on the e-pad comfortably, right from their internal exam till the final university examination. This system enables us to conduct the fair and just exams. It is student friendly, faculty friendly, moreover it is eco-friendly. No student is required to carry any exam stationeries including pen, pencil, paper, eraser, not even their hall ticket, since the system is enabled with iris authentication. It has advanced writing tools, real-time recording of data, easy retrieval of data, and many more useful features. Thank you.
Yes, sir. Now I'll take up the questions.
Jyoti will take up the questions as a panel,
Sure,
if you don't
sure.
mind.
Thank you.
Thank you. Thanks for that very nice presentation. Everybody's eyes popped out when you showed the pictures drawn by the student. So there's a lot of questions about the cost. Okay, KLA is a rich institute. So whether we can afford it is a question. So we'd move on to the next one. We spoke about how we can use technology to harness the power of formative assessments and feedback, how it can be used effectively for summative assessment. We talked about planning at a national stage for OSCE exams. We also spoke about good institutional practices to align instructions. So I'm going to wear the hat of an administrator, and I'm going to talk about how we can enable acquisition of these clinical competencies and what administrators can do. So I'm going to talk about how we can establish and utilize the skills lab, especially in the Indian context where money is a big question. So I'm going to talk about that particular aspect. So NMC guidelines for skills acquisition, for establishment of skills lab, all that has been known. So the first step when we actually think about putting a skill lab together is that you need to have a dedicated team which is willing to work on that particular project. And you need to have an interdisciplinary team. The team which brings in a lot more elements. We need technical support. We need somebody who has an academic and administrative clout. We need somebody who's an expert in the subject. And we need somebody who's a project coordinator. And we also need to find out what are the best practices in the field, because what we know is very little and what is exciting is outside our purview. So we need to visit or we need to identify what is the scope, how other people manage their resources, what operational guidelines they have, what best practices they come up with. We had undertaken a lot of visits to a lot of this. So people collect souvenirs when they go to places, right? When I go to places, I just go and visit their skill lab. So that's what has been happening for the last 2 years. And we need to involve all the stakeholders. We need to get a diversity of input and perspectives, especially with regard to infrastructure. How do they want the users to be the thing? What physical setup they want, including the pantry, bathroom, etc., etc. What is the kind of layout which would suit? So when we do this, you also need to scout for what is the best fit for that particular competency. You don't have to stick with one particular company or one particular product, but you can go shop around and then try and do. And this is one good practice we did. Before we decide on any equipment, we have what is called as a product review. In fact, one is happening right now. We had the clinical HODs who came yesterday and who looked into the mannequins which have been set up. We also need to prepare a business case, because all these things involve a lot of money, involve decision making by the management, and a majority of us here work in private medical institutions where we have to convince the management that this investment, this money, this manpower, and the space and equipment we are buying for this place is worth it. So you need to show. That's one very typical Indian thing. You have to show what others are doing and say that what you are going to do is either similar to it or in line with it, and say what little more you add to that. So that is what is the key feature in selling it to the management. Business secret, okay? Don't tell anyone. Then you need to show actually how your center can be sustainable and what would be your projected cost. So you need to have certain amount of this financial wisdom. Okay, or you need to talk about all these corporate lingo so that they understand what is that you are trying to say. So you need to say how this is in line with the mission of your university. Do we have clear clinical benefits? Do we have clear economic benefits? Can I articulate this cost to the management? This is what it is going to cost for me to run this center for so long. At this point of time, I'm going to break even, and this is where I go for newer investments, etc. And this should be in the form of a data-driven decision making. So in academics also we need to do evidence-based practice or data-driven decision making. And then you need to plan the design brief. You just say, okay, build me a skill lab. So some kotanar, some engineer will come and build some structure. But you need to give a design brief. And unfortunately, all of us don't have a blank canvas. We don't get a space. Okay, this is 10,000 square feet. Build a skill lab in this. We hardly ever get this. They give us, this was built for the museum. This was built for something. You see if you can convert it into a skill lab. So when you're given this, you need to plan little differently for a new building, and you need to plan differently for a building which is already in existence. So that's something which you need to do. And then you need to decide on what courses you're going to do, what type of simulation you're going to do. Is it only task training, or is it going to involve high fidelity things? What is the mode of delivery of training? Is it going to be individualized or team trainings, or what is that we are going to address? So that is a very critical decision which we need to have. Then comes the decision regarding inventory and equipment. Okay, if I have CPR equipment, how many AEDs I need? How many mannequins, Resusani I need for conducting my courses? Where am I going to store them? How am I going to account for all these things? Somebody will take it and run away overnight. So you need to actually have an inventory. How am I going to store it, maintain it? Who is going to do it? So those are the kind of questions which we should be addressing. And we need to buy things which fit our purpose. You can have very high fidelity mannequins. You can also buy Amazon mannequins, which are clothes mannequin. We use it for full body, wherever we need triage, disaster, or any other scenarios which it requires bandaging techniques, dressings. This cost only 4,000 rupees, okay? So we can buy things which help us, rather than go and buy what is the most shining or the latest tool in the market. You need to plan for the workforce. Who is going to run the center? Who is the operational head? Who are the administrative staff? It's very, very important to think about administrative staff and the technicians. And who are the faculty who are going to run this place? Is it full-time faculty? We need to have 1 or 2 people. You also need people who will come part-time. You need ad hoc. You need to employ some people by consultations. You need to have a variety of things to ensure this particular thing is done. You need to have partnerships, okay? This is what is our partnership about. We have an academic partnership with Jeev Raksha. Ram is missing anyway. We have a professional partnership with the American Heart Association and industry collaboration, so that we actually take this forward. This is the most critical piece, training of the faculty, and that is not a one-time affair. We need repeated short training programs which are need-based and focused. Then only things will work. This was the last icon. We run ASCII workshops. We run Jeev Raksha training of trainers. We run airway workshops. We throw our lab open to other things like cadaveric workshops and all. So you need to understand that training is not single faceted, but it is multifaceted and addressing as many people as possible. So that is going to be the real challenge in faculty development. But the most important thing is you need to build your team. It's your team which is going to stand by you, which will make things happen. Okay, I'll finish it in 1 minute. Ensure that the governance has an organizational structure. Who is responsible? Who is accountable for what? Have this particular thing taken down to departmental level. Have coordinators at skill lab level for the departments. Have policies and guidelines. Who is going to use it? When it will be done, etc., etc. So this is what we have achieved. In a short span of 6 months from the time we became fully operational, we are an AHA center. We have spoken about this many things. We have to have an educational plan to integrate simulation into the curriculum. It has to be a planned activity rather than ad hoc activity. I'm not going to go into the details of it because it has already been covered. But what we do is we conduct boot camps for interns when they come. The first week itself, they will be trained on the most basic cross-disciplinary skills. Then we move on and train them in the AHA skills with our resuscitation. Then we take them through simulation scenarios, that is the Jeev Raksha course. So we span it over the course of this internship so that they are trained at multidisciplinary level. So we have made certain certifications mandatory. Best practices in teaching are followed. So we have a certification of BLS course going on. What we need to do to make this effective is we have a skill lab calendar. Who is using the skill lab at given point of time so that we avoid conflicts. We have a curriculum We have a master plan in each department which says that when the skill will be introduced, when it will be practiced, when it is going to be certified. So that's a fairly this thing. We are in the process of preparing a manual for procedural skills, ASCII banks and scenarios, bank for SP cases and their scenarios, and simulation scenarios. So these kind of documentation goes on, and in the new extension of skill lab we are building, we have made one full room for documentation only. This is our annual calendar. You are there in iCON. You need to harness the power of technology. We spoke about it yesterday and today. That's our biggest advantage. And the way forward we see is, instead of teaching only a component of the skill, we need to teach integrated skills, competencies, move from SLOs to outcome-based education, move from teaching isolated skills to a combination of skills. In a scenario, what all you would be doing is what is there. Move from individuals to team training, move from education, simulation for education to simulation for patient safety, move from academic research to real life applications. So what we can do, it is currently a regulatory requirement. All of us are forced to establish a skill lab, but we need to think about it as how we can embed it into the curriculum. It is now in the realm of a few sim enthusiasts, some people who are possessive about it, it's my area. No, we need to make it that it is adapted very widespread. It is currently being taught and being assessed and learned. We need to make sure that it is self-directed and throw open our skill labs to the students for anytime use. So that's what we intend to do. We should make learning fun. And if you kind of have that big picture in mind, then it becomes much easier what all you can do at each level to make that happen. Thank you very much for your attention. Okay. Now that we are done with the presentations, we would like to take questions, and if any of the, we need 5 chairs on the table, 4 at least. Can I request the panelists to move on to the stage, please? Okay, we would like to take the questions from the audience. Yeah, 2 more is enough, 2 are there. If any of you have any questions for the panelists, you can tell what is their name and what it is. Jyoti, the first question has already come.
We'll be working with zero balance, with no maintenance. It's really cost effective. The outcome that we are getting, it's highly encouraging, and this is a move towards digitalization. And once the management and others are happy, then only they have sanctioned now 300 more devices. It's already the order has been placed.
So if you can buy 120 devices for 46 lakhs,
yeah,
I think
to
it's
begin
a
with, we
price.
went ahead with a batch of 100 students only. Maintenance. Next year, we have to pay only 5,000 per device. Initial is 32,000 per device. So for 120 devices, we spent 46 lakhs last year.
In a scheme of things, when you look at the university's budget, which goes into
crores.
Hundreds of crores.
Yes, this is nothing, madam. This is really nothing. But I had a lot of things to convince the management also. But at the end of the day, everybody is happy, and we have been sanctioning, they have sanctioned us even more this time. We initially targeted in on-campus colleges only, and this year, because we have another college in Hubli, the medical college, we'll be including that also. 350 students will be taken up this year.
Hit on this.
No, we'll start with one question,
Okay.
then we'll see if we have time.
Yeah. The first thing about this, I worked with the same ePad in 2015 in China, except for the the eco-friendly part. The first thing was about how to handle the insufficient tooling of students. If you don't consider the learning styles of students, 20 to 25% of the students will fall into a category they are really uncomfortable with this technology. Even though we are dealing with, millennials or Z category of students, still they don't have, I'm not talking about many of them, but at least 25% don't have 21st century skills. How do you tool this or manage this, and what is the adaptation period, and what is the cost for you to do this?
Sir, it's absolutely, the scenario was different 3 to 4 years ago. That time, as I said, it was not a chemically etched surface. After this, there has been a drastic improvement. Although we do a mock test, orientation first, mock test, practice test, mock test, then first internal, second internal, prelims, and then we go for finals. Absolutely, the students have no hassles. I can show you the statistics that each student, what they have written about the system. I am not hyping, but 98%, up to 98% have no, other than a little unsatisfaction for the first exam, that too, first internal. They will be little worried for practice mock. They are not worried because it is not considered for assessment. First internal, they are slightly worried. And this is my own experience. My daughter is also in another medical college using the same technology. Taking her first-hand information, I've been daring enough to implement it. And now she doesn't want to look back because it has 100, the question I'm able to answer to you is, change in the technology and the surface has made a drastic difference. Comfort levels have got really doubled up. And there are no issues, hassles.
Thank you, Jyoti. From 2015, the world has evolved and technology has evolved. For the interest of time and to ensure that there is a distribution across, we'll take this conversation later. Do we have any other questions to the panelists? Yeah. Yes. I'll take Dean sir first, okay? Morning, I already had one issue, so I'm going to talk to Dean sir first. Next you.
Madam, this technology seems to be a wonderful thing for the competency-based education.
Okay.
But the other side, the teacher-student interface, the humanism, the other aspects, the contact between student and teacher is going down because of technology when it overtakes in all places. Have you ever felt like that, or you still feel technology is going along with it?
Is this question directed to somebody in particular?
For anyone.
Okay, for everyone and anyone. So anyone and everyone who wants to answer can do. Maybe we would ask Nicola.
Sir, I think the students are so fast with technology. I think we cannot argue that we should leave technology. But how best we use technology to make our life simpler, that's what we should look at.
You didn't have any concern that now actually the main problem nowadays we are facing is the conflict with the patient and students. And when technology comes here, it makes many things simpler. But whether the humanistic touch, what the Gurukulam thing had previously, there are some aspects which were good, where the teacher, students had some contact, some personal things. Are we losing that when technology overtakes it? That's my question.
I think it cannot fully overtake, sir. We have to wisely choose what we should do with technology.
I can actually reiterate this with what Dr. Farhan was saying. He showed a hammer and he said that's a tool. And technology is just a tool. It depends on what you use it for. You can use it for constructive purpose and also for other purposes.
Yeah, one message from me is technology cannot be replacement. Technology can enhancement. So we not try to replace the practice we are now currently doing to the technology 100% technology based. So we should consider what kind of technology can be implemented to support our current system. So that is my message.
Yeah, thank you, Sayaka, for adding that. Could we take your question, sir?
This is both universities which are using e-platform. We also use high-end softwares, exam-prepared softwares and all for the examination. But how do you ensure the security of the cloud where the answers are stored? is the era of anybody can hack anything, and it is when you are going through this one, hackers are going some other level. So how do you ensure the cloud storage, and what safety audits you do to ensure the safety of those stored in the cloud? And do we get back the repositories back to the institution, or it is always stored in the cloud?
Yeah, the cloud hosting of the data is completely secured, and immediately the downloaded information, they will give us about 15 days to 1 month's time. At that time it is very secure, in the sense they ensure that, and after that we need to download it, otherwise we need to pay for the cloud space also. And it is completely with us, and we convert it into any soft device, we store it in the form of soft copies. And for RTI purposes, and it is completely real-time recorded, including how many times a student used eraser at this fraction of a second, what activity was done, everything is recorded, and for sometimes it just falls and it crashes. At that point, till the last second, everything will be stored, and within a few more seconds we can replace it with, and that lag can be matched up with, again, adjustment of only one particular device for the end exam time also. And storage of data, retrieval of data is completely secure, and it is with us only. They ask us to take our data and store it.
Thank you. She has a black box. Okay, over to you, sir.
Professor Jyoti.
Yes, sir.
My question is related to the assessment of this answer script.
Yes, sir.
Virtual or digital
Yes,
answer
sir.
script.
Yes, sir. Yes, sir.
Do you face any challenges? Number one, you must have got evaluated already. And second thing is, do you foresee any future by getting it automatically evaluated, making use of IC or something, you know?
Yes, sir. That AI has come in for feeding in some keywords or thematics for assessment of descriptive answers also. That is a question, answer to your second question. The first thing you asked was, we were already on to the on-screen evaluations, but our papers used to get scanned and then get uploaded, which would take another minimum 3 days for all the papers, hundreds of paper to be scanned and uploaded. And the screen was so dull and it would not look as live. Now immediately once the exam gets over, within 10 minutes they can be shifted or transferred to the same screens which the earlier evaluation was going on. So it has really cut down the time for scanning and manpower and the cost on the scanners also. We were actually thinking of buying better scanners, but with this we don't have to go for it.
So just to add, sir, we want AI to come in for our FAs, not replace us for the summatives.
Sir,
That's
one more,
a good one.
Madam, quickly, one more thing is, internal exam valuations, we give to individual IPs of the evaluators or the examiners faculty, so that at any convenient time, even when they are sitting in the canteen, they can call some students, even discuss that this could have been done, because it is a low stakes. Only for summative exams, they have to come to our evaluation center for valuations. Okay. That has enhanced the speed of valuations also.
Thank you. Nicola, I have a question for you. You said that you're going to focus more on soft skills, communication skills, and you've been doing it for the last 10 years, right? So could you share us some outcomes data, what this has resulted in?
Outcomes data for the students,
Yeah.
is that right?
Yes.
Okay, so I think it's been a challenging journey. So the evaluation, or rather the assessment tool, is really important. So what we've learned from this journey is that if you make it very task-based or item-based, the students are very smart and they learn to do it just so that they can score the mark on the checklist. Yeah, so I think what we've done as a university is we've moved towards a more integrated way of assessing, changing the rubric such that it focuses more on the broader skills like active listening, like being empathetic, so that hopefully they will see how it applies in a real situation. I don't really have outcomes. We have had feedback from our students to say that it can be quite artificial. And our SPs as well have given us feedback that after a while, every student says the same thing to them in the examination. So I think that's been part of a self-reflective process, and we have re-evaluated the way that we assess communication
So moving
skills.
from skills to competencies.
Competence, that's right.
Very
yes,
nice.
yes.
I have another question to Dr. Sayaka. You said that national level you have made a plan and you are revising it every 2 years, and in 2022 you came up with this. Do you have a national level blueprint for a clinical skills exam?
Thank you. Good question. So we have to create a blueprint, and especially in only some scenarios we create some blueprint. So like pre-clinical clerkship OSCE, we usually use the blueprint. Already we established validated one. But post-clinical clerkship OSCE, we are on the way to improvement. So only scenario created by CATO, which is an organization conducting OSCE, they have the blueprint. But university specific scenarios we created by the university faculty by their own experiences, that is doesn't have perfect blueprint yet. Yeah, thank you.
Thank you very much. It was indeed very nice talking to you. I know there are a lot of questions which are burning. You could catch up with them during the lunch break or during the networking time so that we could do. If I were to summarize what all we discussed today, I think we started by having how to align. We need to have very clear outcomes. So if you don't know where you are going, any road will take you. We need to plan the assessment at the time of planning the curriculum itself. It's a backward design process. We need to involve active interdisciplinary learning, right, rather than being in the silos. I thank Nicola for bringing out that point. We need to have variety. Variety is the spice of education. We need to have a mix of continuous assessments, formative assessment, and summative assessment, and we need to use appropriate tools. But more importantly, we need to match the outcomes to our assessment methods. I think that's the key which came out. Maybe if I can quote Sanjeev sir, measure what is important and not what is easy, right? And FA is an integral part. Feedback is the most important element for learning. Ensure that there is a clinical relevance of what they are learning, even in the preclinical OSCE. So that improves the authenticity and real world applications. We need to have clear assessment criteria and blueprint. We need to share that with the student. It is okay if the students know the OSCE checklist, okay? If you have 100 stations and he has mugged up 100 checklists, I think it's okay for an undergraduate students. I don't have any qualms in sharing OSCE checklists with the students. We need to have, for all this to happen, we need to ensure that there is an adequate faculty development, there is a collaboration, and this collaboration happens not only inside your department but also outside at interdisciplinary, and feedback is the most essential aspect. We need to get feedback, we need to reflect, and we need to think about how we can improve. So that finishes the session with these lovely ladies on how to align instructional design with assessment. Thank you very much for the patient listening. I know we went into the lunchtime, but still you stayed with us.
We thank the anchor and the panelists for such a great session. May I request Dr. V.N. Mahalakshmi to honor our panelists. Dr. Nicola, Dr. Kirtana R. Nayak, Dr. Sayaka, and Dr. Jyoti M. May I request our Provost, Professor P.F. Kotu, to honor Dr. V.N. Mahalakshmi.